Thank you very much to the Philippine Society for the Study of Trophoblastic Diseases for this opportunity to be part of this very important webinar. The topic that's been given to me is a continuation of the first lecture, and I'm going to talk about adverse drug reactions and focus a little bit more to chemotherapeutic agents for gestational trophoblastic neoplasia. These were the questions that I was given to answer. Some of them have been excellently answered actually already by Dr. De Hiro. So I think the main purpose of my presentation is to serve as a bridge between the first lecture, which already tackled the management of GTN with brain mets, the ADRs from the chemotherapy, the cutaneous ADRs, especially the serious cutaneous ADRs and their management, and bridge it to the third lecture, which will then give more focus and detail on the severe cutaneous adverse drug reaction. So I'll begin with the first topic, which are what are the types of adverse drug reactions. We refer to these kinds of adverse drug reactions as the ABCs of adverse drug reactions. A stands for augmented, B for bizarre, C for continuous, D for delayed, E is ending of use, and F is failure of treatment. For this particular case that was already discussed, the main focus is actually the type A and B adverse drug reactions, specifically the type B. The type A augmented ADRs are the side effects that we typically recall when we think about the noxious effects of drugs. And these are effects that are higher in intensity or magnitude than the expected pharmacologic effects. They occur as an extension effect or part of the therapeutic effect, or not as part of the intended therapeutic effect, but as a side effect. So that's really a load full of words, but all that it means is that in the type A or augmented adverse drug reaction, this can be fully explained by the mechanism of action of the drug. The mechanism of action brings about the therapeutic effect. And so therefore, the first kind of augmented adverse drug reaction is really an extension of the therapeutic effect, and typically, therefore, has a dose-dependent mechanism. This is what we call the augmented extension effect. So, for example, if you're using insulin, the intended effect of insulin is to bring down your blood sugar, to control it. But if insulin is mismatched with your meals, with the caloric intake, it can cause hypoglycemia. So that's called an augmented extension effect. It's predictable, it's dose-related. And so all that has to be done is really to withdraw or to reduce the dose of the drug. Another example is heparin. Heparin is supposed to, is an anticoagulant, but if you give too much of it or you don't monitor, for example, unfractionated heparin, it can cause bleeding. Now, the augmented side effect, on the other hand, is an ADR that is not the intended or therapeutic effect, but can still be explained by the mechanism of action of the drug. It's again predictable, dose-dependent, but it's unrelated to the goal of the therapy. So for example, NSAIDs, their main mechanism of action has to do with inhibiting the COX enzymes. And this has good effect for pain or for inflammation, but it can also affect certain functions in the body, like for example, the production of the mucous membrane that lines the intestines. And so the use of the NSAIDs, while they're good, can also bring about upper gastrointestinal bleeding. Or salbutamol. Salbutamol is a beta agonist. It will cause dilatation of your bronchi and relieve wheezing in asthma. But because of its effects on the other beta adrenergic receptors, it can cause, for example, tremors or tachycardia. Now, in the case that has been presented, we can point you to methotrexate and the other chemotherapy agents as having caused a type A adverse drug reaction. You know that methotrexate is a folate derivative that inhibits several enzymes responsible for nucleotide synthesis. So this leads to suppression of inflammation as well as inhibition of cell division in neoplastic diseases. So there is no production of DNA and RNA, arresting the production of tumor cells. However, the unintended targets of this effect, this mechanism of action, are also the other rapidly dividing cells, such as the blood cells. And we know that for at least 3 of the chemotherapy agents, as Dr. De Quiros has explained, there can be effects on the blood cells through myelosuppression. So the rapidly dividing cells, such as the blood cells, are the collateral damage. And therefore, the occurrence of pancytopenia can be considered a type A side effect of several of the chemotherapy agents. So that's type A or augmented, which are dose-related ADRs. The next type of adverse drug reaction are the bizarre or type B adverse drug reactions. These are hypersensitivity or idiosyncratic reactions. They're unpredictable. They're unrelated to the mechanism of action of the drug. They cannot be explained by the pharmacologic effects of the drugs. There are also no conventional tests to demonstrate which patients might develop these ADRs in order to theoretically prevent its occurrence. Although internationally, they have been investigating certain of our HLA types as being related to the occurrence of type B or bizarre ADRs. These are not dependent on the dose of medicines. They can happen whether you use low dose or high doses of the drugs. And these are some examples of syndromes of type B ADRs in clinical practice. Connective tissue diseases such as drug-induced lupus, granulocytosis. So that's a clue. Typically, if it's just one cell line that is affected, especially the white blood cells, this is not the type A ADR, but rather a type B or bizarre adverse drug reaction. Drug fevers, and of course, later on, we'll talk about this. The severe cutaneous adverse drug reactions are also mostly type B or bizarre ADRs. These bizarre ADRs can occur immediately, such as the type 1 hypersensitivity, the anaphylaxis, the acute anaphylactic reactions. But many of them are actually the 4th type or the delayed type hypersensitivity, which typically happens several days after exposure, 24 to 48 hours, but some can happen months later. So it has been seen that sometimes for Stevens-Johnson syndrome, due to anti-seizure medications, even after they've been exposed to the drug already for several months, they still could potentially develop Stevens-Johnson syndrome. Even for anti-thyroid drugs, carbimazole, methimazole, even if they've been taking the drug already for several months, they can still develop SJS. And they cannot be explained, as I said, by the known pharmacologic action or the mechanism action of the drug. This type B or bizarre ADRs have no formal dose response curve, again, because they can happen at any dose. Small doses can elicit the same reactions once the hypersensitivity has been established. But typically for most drugs, there is a dose range where the most number of bizarre adverse drug reactions happen. The reactions typically would disappear on discontinuation of the drugs. And so what is most important is to really just recognize the ADR so that the drug can be withdrawn. And typically they have an immunologic basis for the ADR. These idiosyncratic drug reactions do not occur in most patients. So that's a clue. They are typically rare and develop most unpredictably in susceptible individuals only, although some would have a genetically determined abnormal response to a drug. Let's say if you have a G6PD deficiency, then you could potentially develop a hemolytic anemia when you use sulfonamide drugs or aspirin. Now, these are the types of hypersensitivity reactions. Now, as I said, type 1 is the typical anaphylactic reaction, and type 4 is the delayed reaction, which will be explained later on as well by our next speaker as one of the mechanisms of action for developing the serious cutaneous adverse reactions, especially SJS. These severe cutaneous reactions, which are type 4 hypersensitivity reactions, would involve not only the skin, but the mucous membranes of various body openings, typically with systemic effects. Many references list down 4 different types of scars: the Stevens-Johnson syndrome and TEN, the DRESS or the drug reaction with eosinophilia and systemic symptoms, the AGEP or acute generalized exanthematous pustulosis, and the generalized bullous fixed drug eruption. So in our patient, she was actually, the first impression for her was actually maybe she had Stevens-Johnson syndrome or TEN, toxic epidermal necrolysis, no? which are spectrum of fatal mucocutaneous adverse reactions characterized by rapidly progressing, purpuric, atypical target-like rashes with blisters, cutaneous sloughing, and mucosal involvement. The two are differentiated by the degree of skin involvement, where the SJS is typically less than 10% of body surface area, would be the skin detachment. TEN is more than 30%, and the overlap syndrome is between 10 and 30. So these are just some pictures to show you the mucosal involvement in the mouth, the involvement of the face, looking at the bullae. And you can see the wide involvement. This is TEN and the sloughing off of the skin. Well, good news is that it's relatively rare, 1.6 to 9 cases per million in the US and 1 to 2 cases per million per year in Europe. But once it happens, the overall mortality is high, depending on the body surface involved. And so for SJS, it's around 10%. And because the body surface area involvement of TEN is more, it's around 50%. And it can also cause irreversible sequelae to the eyes, skin, and the lungs. But typically, they're caused by a limited number of drugs, including anticonvulsants, sulfonamides, sulfa-containing drugs, certain antibiotics, NSAIDs, and uric acid lowering agents, and as what you will see later, chemotherapy agents. These mucosal erosions or ulcer have a variable extent of detachment and can happen typically or persist typically for a period of 1 to 3 weeks. The mucosal lesions may involve the oral cavity, the lips, the conjunctivae, and the genital areas. And they're usually widespread with predilection on the trunk and consist of atypical flat target lesions. And there are systemic symptoms which can develop like fever, generalized malaise, flu-like symptoms, and possibly organ involvement. The scars, as I said, involve 4 different kinds, and you can also list down toxic erythema of chemotherapy, typically staphylococcal scalded skin syndrome looks the same as the other scars, but thankfully this SSSS happens mostly in children because adults already have antibodies to the toxin of the staphylococcus. It's important to recognize them because management and the prognosis may be quite different, but recognizing them would be quite challenging, and that's why specialty or subspecialty referrals are needed because they all present with desquamation, bullae, erosions, mucosal involvement, and systemic symptoms. Now, misdiagnosis of the most life-threatening condition, which is the SJS10, is needed, but if we wrongly misdiagnose them, they may result in unjustified admissions to the ICU, leading to increased costs and expose patients maybe to unnecessary treatments. Now, scars are important because, as you know, the skin is a very important physical barrier. So with the sloughing off of the skin, you can introduce infections, and also there will be loss of fluids and electrolytes through the sloughed off or the exposed skin areas. So this is a sample of a bullous, a generalized fixed drug reaction. I think Dr. De Quiros also showed you this. This is another example. They're typically hyperpigmented, the bullous fixed drug eruptions. Our patients' eruptions started a day after or 24 hours after the end of the high-dose Emaco. And this is already day 2 of the high dose, no, rest day, I'm sorry, rest day 2 after the EMACO. And you can see that it wasn't as widespread. And then just then a day later, you can see already the extension and the sloughing off of the skin. You can appreciate that there was not much mucosal involvement. There was some angular stomatitis, I think, some dryness of the lips, some chylitis, but there was really not much mucosal involvement. And then you can appreciate the rapid progression. This is day 2, rest day 2, and then this is rest day 3. But we also appreciate actually that pictures were taken every 3 to 4 days. So you can see also the rapid improvement, so that by rest day 12, you can see the nearly full resolution of the skin lesion. Our third speaker will still speak at length about the bullous fixed drug eruption. So think of this as an introduction. The FDEs are typically defined by a limited number of lesions that heal just with cessation of the drug or ingestant, often leaving residual hyperpigmentation. They rarely manifest with bullae and rarely by widespread blistering. And again, distinguishing it from the other scars is sometimes really difficult. These bullous fixed drug eruptions are again due to a delayed classical type 4C hypersensitivity mediated by the CD8 T cells, where the drug binds to the basal keratinocytes and stimulates the inflammatory process by causing the release of lymphokines, mast cell, and antibodies, which in turn causes the damage to the basal cells. And again, there seems to be a genetic susceptibility to develop FDE because of this HLA-B22. Now, taking a look at EMACO, the different chemotherapy agents that were given to the patient, you can see that all of them are actually related to the occurrence of skin and connective tissue ADR. So this is taken from the VG Access, which is the reporting system of the WHO in Uppsala in Sweden that collects the data from many international centers. So for etoposide, there were around 50,000, nearly 48,000 reports. And of these reports, around 3,000 were on skin and subcutaneous disorders. So you can see TEN, bullous diseases, and Stevens-Johnson syndrome. But it is actually methotrexate that has the most number of reports, no? Nearly more than 160,000 reports, with 17,000 of them on skin and connective tissue disorders as the ADR. And again, you can see that quite a number of them are Stevens-Johnson, almost 200 for SJS and TEN. And that's aside from the bullous dermatitis, bullous diseases. The rest, EMACO, actinomycin or dactinomycin, again, not as many as methotrexate. Again, appreciate how many reports there were on methotrexate as compared to actinomycin or dactinomycin. And less reports on SJS and bullous disorders. And for cyclophosphamide, again, more reports compared to actinomycin, but not a lot compared to, for example, methotrexate. And finally, for vincristine or oncovin, really the most common reports for vincristine are actually the blood and lymphatic disorders. But again, you appreciate that there are nearly 3,000 reports on skin and subcutaneous tissue disorders, and most common of which actually is alopecia, which our previous lecturer has also emphasized. And again, Stevens-Johnson's and TEN and bullous disorders are also associated with it. And so what we can say, therefore, is that nearly all of the drugs that were given to the patient, the chemotherapy agents, may have or may induce actually the scars, especially SJS, as TEN, as well as the bullous skin disorders, any of the EMACO actually. Now, to continue with the different kinds of ADRs, winding up, The next kind is the so-called continuous kind of ADR, which happens after a prolonged use of a drug even at the normal dosage. This is related to dose and duration of treatment and typically multisystemic. So the most common example of these are drugs which are maintained for several weeks and months, leading to systemic diseases, such as when you give steroids for a long period of time, you develop obesity, osteoporosis, hypertension, diabetes. Or for the drugs for tuberculosis like INH, with prolonged use, it can result to hepatitis and neuropathy. Next are the delayed type of ADRs. These are seen when a drug used at some earlier time has adverse effects observed, typically on the next generation. So women, for example, who take diethylstilbestrol, they can cause vaginal and other reproductive organ damage in female offspring, such as vaginal cancer, or the intake of thalidomide in the 60s by pregnant women, which result in various kinds of congenital malformations, especially phocomelia, or the foreshortened extremities. The other types of delayed ADRs would be the development of carcinogenesis, again, teratogenicity, and even immunotoxicity for the next generation. Next is the ending of use, or the withdrawal syndromes. When a drug that is used in the long term is suddenly stopped, the patient suffers a form of withdrawal reaction. And these are also some drugs where patients exhibit tolerance or have some dependency potential. And some common examples is the intake of clonidine, a drug for hypertension, where if you withdraw it, you develop rebound hypertension, or adrenal insufficiency after stopping prolonged steroid use, or seizures after acutely ceasing anticonvulsants, you actually develop seizures. And the last kind of ADR are the failure of treatment. This is when substandard drugs or counterfeit drugs are taken instead of the actual drug, or the drug itself may have toxic excipients and may not only cause ADRs, but will not actually work. Another explanation for a type F ADR is actually the development of antimicrobial resistance. And this kind of ADRs is very important because this is we need to recognize them as public health threats. ADR monitoring systems should be able to pick them up. And once detected, the information can be used by the drug regulators, the concerned industry, and the institutions that use these drugs to then withdraw these drugs. So in the Philippines, one example of this is the case of oxytocin a few years back, where generic oxytocin was marketed and it had failed to work, causing deaths in some of the women who had delivered. And so there was a court case in this for a long time, but eventually it was very important because it brought to the attention of the public, that a type F ADR is potentially life-threatening. Now, the next question that I'm supposed to answer is, what are the safety profiles of the different chemotherapeutic drugs used in GTN? And it will not do justice if I do it all over again, because I think Dr. De Quiros has really very excellently lectured this already. So what I will try to do is to just give a little bit more focus on the more common ADRs. And this is a table that's taken from the Atlas of GTD by Dr. Cagayan. And so what we can see is for the EMACO, if you take a look at them, the first three, the EMA, they tend to cause the type A ADRs, the pancytopenia. And you can see this in our patient. There was a drop in all the cell lines, RBC, WBC, leukopenia, and even the platelets thrombocytopenia. Now, if you include the C, it becomes EMAC. All four do tend to cause nausea and vomiting. And they do tend to cause both the immediate vomiting, which is due to the peripheral pathway, the acute phase of chemotherapy-induced nausea and vomiting brought about by the release of serotonin, as well as the longer term or delayed chemotherapy-induced nausea and vomiting, which is mediated by the central pathway. So that's EMAC. And please take note that the last one, oncovin, as well as the cisplatin, which is used in salvage therapy, also tend to cause neurotoxicity in the form of peripheral neuropathy and even ototoxicity. Now, all of the EMACO do tend to cause or have been associated with scars. Now, I just want to focus on one of the drugs, and this is the cisplatin-based, and this is cisplatin. Just to emphasize that cisplatin is very important in that it not only causes nausea and vomiting, but and neurotoxicity in terms of the peripheral neuropathy, which is quite common. But in certain predisposed individuals, it may cause nephrotoxicity, even acute renal failure. And these are typically in older people, those who are with comorbidities and pre-existing kidney diseases, and the concurrent use of nephrotoxic medications. And it is thought that this effect of cisplatin, is due to the accumulation of cisplatin in kidney cells because it is cleared through glomerular filtration and tubular secretion, the biotransformation of cisplatin into a more potent drug, a reactive thiols, and because again of the cellular targets of cisplatin, they again can potentially have cytotoxic effects even on the kidneys. Finally, the last questions I have to answer is what factors influence the toxicity of chemotherapeutic drugs, and in the case presented, which drug or drugs could have caused the skin toxicity? Again, Dr. De Quiros has very excellently discussed this. Some of the factors related to development of adverse drug reaction are patient-related, like their age. Typically, the older individuals have more ADRs. Women do tend, for some reason, tend to have more ADRs. Certain genetic influences, the presence of concurrent diseases and previous adverse drug reactions. The more compliant you are, actually, the greater is the tendency to develop adverse drug reactions. Drug interactions, so the more medications, the greater is the tendency to develop ADRs, and miscellaneous other patient-related factors. And of course, the drug-related factors would be the dose, including the cumulative dose, which is related to the duration of exposure, and the inherent toxicity of the agent. So just then to point out to you that, for example, for cisplatin, while an older age leads to greater tendency for neurotoxicity and nephrotoxicity, a younger age is actually highly associated with greater occurrence of nausea and vomiting. So this is something that we can take note, Ototoxicity, neurotoxicity, and nephrotoxicity older, while younger, greater possibility of nausea and vomiting. Now, in the case that was discussed, which are the possible drug offenders for the scars? It is hard to determine this given the number of drugs that was given to the patient. Secondly, it's also hard because in the way that we try to determine causality, we take a look at temporality, drug first, and then the development of adverse drug reaction. And this is hard because the patient was exposed to several drugs before she developed the severe cutaneous adverse drug reaction. It's also hard because it is hard to re-challenge the patient with the possible offender, because it's a serious adverse event. And because scars are typically bizarre or idiosyncratic, you will not see any dose response. And there are actually no other plausible explanations at the time when the scars happened. The patient did not yet have any infection. And therefore, if you think about it, what could have potentially caused the severe cutaneous adverse drug reaction? As I showed you in the VG-based WHO database, all of them are associated with scars, SJS, but mainly predominantly methotrexate. The anti-seizure medication that was given to the patient also has a potential to cause the scars, but is less likely because it's actually the more common aromatic anti-epileptic drugs such as phenytoin, carbamazepine, phenobarbital, and lamotrigine that more commonly cause it rather than the second generation AEDs. So I think that's the last of the answers to the questions. And these are some of the lessons that I learned when I studied also or research for this presentation. Scars can be life-threatening. There are several differentials that make it hard to recognize them, and so referrals to dermatology, immunology may be warranted, even in this case, toxicology. And early recognitions of various ADRs, including scars, is needed because some of them, especially the type B, cannot be prevented, but if recognized early, intervention can then be given. So with that, thank you very much for your time and attention.